part of Metabolic Masterclass. We are so excited to discuss an interesting topic, which is PCOS or PCOD, which not only impacts the reproductive years in younger and middle-aged women, but also has a prolonged impact in the form of poor cardiometabolic status long-term. We are very pleased to introduce our consultant gynecologist, and we are very much thankful to them because they were very busy with their schedule. In spite of that, they all came to discuss this very interesting topic. Hats off to their dedication for preserving the fetal and maternal health in our society. I myself, Dr. Tangadurai, I am a general surgeon, and now I am moving more towards the metabolic health, and have started a company called Dr. Gold Healthcare. So other gynecologists can introduce themselves.
Thanks, Tangadurai, for a wonderful introduction, and thanks for supporting women and making a change in the metabolic disease sector. So I'm Dr. Vani Ayasamy. Way back in 2002, we all studied together in a prestigious college, Madras Medical College. It was a wonderful time, and now we are all budding consultants in different aspects. So here, a wonderful topic, which is polycystic ovarian syndrome. This one disease is one in which lifestyle modification can bring in a beautiful change. Whereas in other diseases like endometriosis and other group of diseases, whatever you do, only the medicine works, whereas lifestyle doesn't work. So nice to be a part of this session. And why we have chosen this topic is PCOD affects women close to 1 in 10. And it is a genetic, hormonal, metabolic, and reproductive disorder. It is the most important cause of female infertility in this era, and it can also lead to serious conditions like obesity, anxiety, depression, infertility, endometrial cancers, type 2 diabetes, and cardiovascular disease. And many women doesn't open up having an irregular cycles. They're scared of infertility. They're scared of being obese. So especially Indian women requires a topic and a lifestyle change that would affect PCOS in common. So let us get into the session and let us invite other friends too. So here goes Dr. Kalaimani. Introduce yourself.
Hi everybody, this is Dr. Kalaimani, consultant logician. Happy to be part of this discussion. Currently I'm attached with Sudha Fertility Center and doing my own private practice. It's like PCOD is a major health concern because wherever we go, like among young adolescents and young adult women, almost 10 to 20% of them are suffering from PCOD, which is a major health problem as of now. Happy to be a part of this discussion. Thank you.
Hello, hi everyone. I am Dr. Pradeepa, working as a gynecologist and laparoscopic surgeon in Bangalore. I'm very happy to be part of this session. PCOD creates, a lot of panicky situation among the among the people. So whenever a scan shows PCO, they get panicky and then they think that, yeah, I got a disease and then I don't get pregnant. So this session, I hope that it creates a lot of awareness. What is PCOD and what are the effects it causes with the general population. And see, after menarche, many of the women will have polycystic ovaries. So they say they require all the 3 criteria to be present for them to diagnose it as a PCOD. So this session will be very helpful for everyone. Yeah, I'm also waiting for the same. Thank you.
While the younger generation are suffering from infertility and subfertility, I am amazed and seeing the women from Hunza Valley, which is in North Pakistan, are even conceiving naturally at the age of 65. So the reproductive years may not be a struggle if you follow a very good lifestyle as them. And in addition to that, they are having a very good micronutrients in the form of colloidal mineral water they are having, and also they are having a very good alkaline water naturally, and a very good lifestyle, and they live in harmony with nature. So we need to proceed in the direction. So why you are more worried at PCOS? Is it just a simple acne or just a matter of hirsutism? No, it is not. It is actually impacting a very great impact over the reproductive cycles, because in PCOS there occurs a chronic anovulation, and all the reserves, ovarian reserves, are simply wasted just because of this PCOS, right? So it leads more of infertility and subfertility. When the current generation is facing a condition like they are having an early menarche, and when it is coupled with the late marriages, and it's more or less many of the patients are moving in for subfertility and infertility. In pregnancy, the complications may be miscarriages and hypertension and gestation diabetes mellitus. Not only that, the fetal health is also affected, maybe a small for gestational age or low birth weight for gestational age, and it is also associated with morbidity and mortality, and it causes metabolic syndrome in the growing children as well. And long term, it causes metabolic syndrome. The PCOS is just an iceberg. It can be the initial symptom of metabolic syndrome, and all the components like hypertension, dyslipidemia, and obesity, like all those things, and diabetes may occur 5 to 10 years later, or maybe a decade after that. The women who are suffering from PCOS are prone to have estrogen dominance because of the anovulatory cycles, and they are running a risk of endometrial CA. So I would like Dr. Kalimani to walk us through the normal reproductive cycle and what happens in PCOS. Over to you.
Yeah. Okay. Let's just see about the difference between normal physiology in ovulatory patients as well as pathophysiology of PCOD. The periodic. See, the normal menstrual cycle, the basis of normal menstrual cycle is the pulsatile release of GnRH from, as we all know, it's due to pulsatile release of GnRH from the hypothalamus, which in turn secretes FSH and LH from the anterior pituitary. And as ovary is the end organ for FSH and LH action, the FSH action will cause follicular maturation, and the peak of LH will cause ovulation. And once ovulation occurs, the release of progesterone will induce LH hormone stimulation, which in turn leads to which is responsible for the second half, that is the secretory phase of the menstrual cycle. See, this is what happens in patients with the normal menstrual cycles who are ovulating regularly. Coming to polycystic ovary syndrome, the basic pathophysiology is increased pulsatile release of GnRH. Because progesterone is the main inhibitor of pulsatile release of GnRH hormone. In the absence of ovulation, lack of progesterone will lead to unopposed, that is the frequency of GnRH release will increase. The LH secreting cells from the anterior pituitary are more responsive to GnRH rather than FSH secreting, and the excess LH will lead to excessive androgen production and dysovulation in PCOD patients. Excess androgen, which can in turn lead to excessive synthesis of insulin, which becomes a vicious cycle. So the anovulation continues, which manifests as irregular cycles, and the androgen excess due to hyperinsulinemia can cause all the clinical and biochemical hyperandrogenemia.
So that occurs premature follicular arrest, right?
Pardon? So
that occurs a premature follicular arrest.
Yeah. That is because
Instead
of
of
lack of
the normal ovarian
that is
reserve,
because of
FSH,
FSH, altered ratio of FSH and LH. There will be LH predominance in anovulatory patients.
okay.
See, you can see in the slide that rhythmic release of the FSH-LH ratio will be altered because of abnormal pulsatility release of GnRH, which in turn lead to anovulation, which is the main reason for hyperandrogenemia and other clinical consequences of PCOS.
Okay. Dr. Vani, could you run us through this slide?
Yes. See, as we all know, the Rotterdam criteria of defining PCOD is usually what happens is three criteria have been given. If any two turns out to be positive, then they categorize themselves into polycystic ovarian syndrome. One is anovulation, which can be ovulatory dysfunction. Second one is hyperandrogenism. And the third one is polycystic ovarian morphology by ultrasound. So when we categorize PCOS, what do we actually do? There are different types according to the modifications that can be done. As every person in this meeting, we are insisting on insulin resistance as a major factor and hyperandrogenism as a major factor. And as we all know, chronic inflammation is a newer terminology that makes PCOD as one of the reasons. So first thing is it really PCOS? How do you, as we know, we put in the Rotterdam's criteria, and if it is really PCOS, yes, then we go into insulin resistance. If the insulin resistance is present or not. If it is present, it is insulin resistant PCOS. As we all know, insulin resistance accounts to the major chunk of the PCOD. And if insulin resistance is not there, there could be various other reasons, like, as I said, chronic inflammation and only elevated androgens because of, not because of the adipose tissue, but because of the adrenal gland. So, and people used to take progesterone only pill or some oral contraceptive pills, which might lead to a chronic anovulation and a sort of a PCOD symptom. So we generally terminology roughly given to that is post-pill PCOS. And in case there is a sign of chronic inflammation, we call them as inflammatory PCOD. This is an upcoming topic in PCOD. And the next thing, if suppose there is no signs of inflammation, no signs of any hormonal intake, then we check dehydroepiandrosterone. If that is an androgen only elevated, not the total testosterones or the free testosterones or sex hormone binding globulins, then we term them as adrenal PCOS.
Okay, thank you. So this is a new terminology called yeah.
So as Dr. Kalimani said, PCOD is not a disease. It's mainly a hormonal imbalance. So yes, FSH, LH is high, insulin is high, androgen is high, prolactin is high. So I mean, it's mainly a hormonal imbalance. So PCOD, PCOS both are same. And as our Dr. Vani said, the polycystic ovarian morphology, PCOM, okay, immediately after menarche, usually the immature hypothalamo-pituitary ovarian axis causes this kind of irregular cycles, okay, and scanning also in the initial few cycles there will be polycystic ovarian morphology. So I mean, we don't have to worry that it is a PCOD or PCOS, okay. So I think in that case we have to see that excess androgen also, and when they have all these features, then we can label them as PCOD.
Maybe an age up to 18 or 20 years, we may not worry about PCOM morphology, right?
Yes, actually, I agree with Ranta. See, there are like two entities. Patients are having regular cycles, but ultrasound is showing PCO morphology means like we need not worry about, especially in prepubertal girls, in adolescent girls, we need not worry about that. And the other one is, it's as she told, it's because of immature HPO axis, they may have irregular cycles without the other criteria. That kind of patients, we just need to reassure them. Once the HPO axis gets mature, the cycles will become all right. So they can wait till the age of 18 years.
Yeah, correct. Thank you.
Okay, thank you. So this is again a very interesting term called lean PCOS, which you are all facing nowadays, I think, in your clinical practice. And what we think normally is in lean PCOS, there is no insulin resistance, right? It is not so because it is a right? Yeah. Actually, there is insulin resistance, which is not diagnosed by fasting insulin levels. So we have to look for the HOMA M120. That means we have to measure the insulin levels at 120 minutes, which will give you an elaborate history. That is the area under the curve will be more when compared to the normal patients. So we have to look postprandially as well, not only the fasting insulin levels. The lean PCOS are more having a abnormality in the postprandial insulin levels and not in the fasting insulin levels. And we have to rule out again the hypothalamic amenorrhea, which may mimic PCOS, in which case there is a decreased leptin levels that causes the mimics the PCOS symptoms, right? And other types we have to take into account are post-pill, adrenal, or inflammatory, which may have a lean morphology. So what we are having nowadays, the current system is having a symptomatic management. That is, whether it can be in anovulatory cycles, they can go for OCPs, and for tackling the insulin resistance, they are using metformin. And for ovulation, they are using the ovulation injection drugs like clomiphene. And surgically also, if it is resistant, we may go for wedge resection laparoscopically and ovarian drilling. So there is no actually a magic pill for the PCOS, right? So what is this? So we are actually aiming at multiple targets, like all those things. We are moving to genetics, or else the LH hypo. That is the HPO axis dysregulation, or it can be an ovarian pathology and androgen excess. When you're having a multiple targets, you can't hit the bullseye, right? So we need to focus and move towards the root of the illness, root cause of illness. So this is a clue in which in gynoid obesity, there will be more of subcutaneous, that is the gluteofemoral fat, right, deposition, which gives them a pear-shaped obesity. And in male, there is an android obesity in which there is more of the visceral fat accumulating in the upper portion of the body. But when we look at PCOS women particularly, let it be thin or obese patients, they're having again an android obesity, which is secondly occurring due to the insulin resistance and hyperinsulinemia. This is the key here. So instead of looking at the genetics, hormonal, ovarian pathology, or some other things, we are actually missing the elephant in the room, which is the insulin resistance and more of hyperinsulinemia, as well as the leptin resistance, which occurs secondary to the hyperinsulinemia, which is the main cause. So when you treat this one, everything, the hormones comes in harmony. The hormonal imbalance becomes balanced. Everything comes in harmony and sets in, and the reproductive cycles are again going to revert back towards its normal cycles. So what happens in PCOS? So the root cause is the environment, the ultra-processed foods, the introduction of sugars. All these things are causing hyperinsulinemia and insulin resistance. Actually, the hyperinsulinemia and insulin resistance are two sides of the same coin. And whenever there is hyperinsulinemia, there is decreased sex hormone binding globulin, which causes increased free androgens. And also, the hyperinsulinemia causes leptin resistance, which impacts the GnRH neurons, in which there is increased LH production and decreased FSH production. The Theta cells are more vulnerable, that is, LH along with hyperinsulinemia both acts in synergy to produce increased androgen production by the Theta cells. This causes hyperandrogenemia, and this hyperandrogenism is seen in women in the form of acne, hirsutism, and male pattern baldness, and the acanthosis nigricans in the skin folds, particularly in the neck, and even in the face, right? And in axilla, armpits, abdomen, and also it can be seen in the thighs. And there occurs a premature follicular arrest due to the decreased FSH as well, which often leads to anovulatory cycles. So where is the key here? The key here is hyperinsulinemia. And what leads to the hyperinsulinemia is the environment which we are exposed, right? The ultra-processed foods, the sugars, all these things leads to hyperinsulinemia. When we break that cycle, all these things, the hormones imbalance are all downstream effects. So we have to more focus on the hyperinsulinemia and insulin resistance, which is often seen in PCOS in almost all the cases. So in normal reproductive cycles, we need a certain cutoff point in which there should be a big increased energy reserve in the form of subcutaneous fat so that the reproduction proceeds. Which means for somatic maintenance, even in starvation, there will be somatic maintenance, but it will not support the reproduction. We need to have at least a minimum requirement of energy reserves for the pregnancy to proceed without any complications. This is what we see in hypothalamic amenorrhea, that is, which can be seen in even in athletes, in which there is over-exercising, and it can be seen also in anorexia, that is the under-eating. More teens are inclined to this, that under-eating, and more worried about their physique. They may even suffer from hypothalamic amenorrhea, which is the differential diagnosis of PCOS. And what we are seeing in PCOS is leptin resistance, in which the brain perceives as if we are in starvation. So there is a decreased metabolic rate, secondary to hyperinsulinemia, and also the brain perceives and there is an increased overeating. And all these things downstream causes increased insulin resistance and obesity. So we have to also address these stress levels. And women nowadays are facing more and higher stress, in which there occurs the progesterone or pregnenolone steal, in which more of this sex hormone production is diverted towards the cortisol and stress hormone production. Whenever there is a higher stress, the reproductive cycles are disrupted. So the reproductive cycles are disrupted in a way it affects the GnRH neurons and it causes decreased LH and FSH. And also the chronic stress uses of the progesterone, and low progesterone often leads to subfertility and infertility. So what we have to focus more on is the environment, the epigenetics, which has a major impact over the hormones. So the foods we have to avoid in PCOS is sugars, refined grains, ultra-processed foods, all the junks, and we have to get rid of these cheap vegetable oils, which is almost seen in all the restaurants. We should not dine out frequently. We have to get rid of the seed oils, which is more of inflammatory. Is actually the omega-6, which causes the steatohepatitis. It causes hepatic insulin resistance. Whenever the hepatic insulin resistance occurs, it often causes a systemic insulin resistance. So we need to.
I would like to add the newer topic in PCOD these days is non-alcoholic liver disease due to PCOD. So this is a newer topic which has been coming up because most of the PCOD women after age of 40 are presenting with elevated liver enzymes and mostly a non-alcoholic fatty liver disease.
Yes,
so
yes.
this is yes.
I'll come to that.
You to address on this as well.
Yeah, sure. Maybe 30 years prior to this one, this current era, if there is something like a fatty liver, the primary causes always alcohol, right? But what we have been seeing in this present generation, even in the pediatric age group, is the increased incidence of fatty liver disease, which occurs even in children and also in teens and young adults, that causes fatty liver disease in the form of steatohepatitis, in the form of steatosis, or even in the form of steatohepatitis. And this causes the hepatic insulin resistance. The hepatic insulin resistance often leads to the systemic insulin resistance. So we need to more address towards this. This is due to increased sugar intake and intake of refined ultra-processed food, and also the seed oils.
Okay.
There occurs increased DNL, that is the de novo lipogenesis happens in the liver. So the paradigm is now shifting from the adipocentric view to the hepatic view, hepatocentric view.
Okay.
In the pathogenesis of early insulin resistance, which you are all facing nowadays in our current society.
Okay.
Is that answers your question?
Yes, yes, yes. And
80% of all your weight loss programs, no. 80% is because of your diet pattern, and 20% only we can advise exercise.
Yeah.
Yes, I also was about to ask the same question.
Sure. In almost all the labeled foods, you will see a pattern like there will be increased sugars, and along with that, there will be refined flours and admixed with seed oil. In almost all the cases, this is actually a recipe for disaster. This is a recipe to become obese. This is a recipe to become insulin resistant. So we need to eliminate all such foods: excessive sugars, seed oils, refined flours. So we have to move towards the whole grains, our traditional grains. We have to include more pulses and the green leafy vegetables. All those things comes into account, and we have to periodically fast and feast. We should our pattern of eating is like we are taking at least 3 to 4 meals a day, admixed with snacking, 2 to 3 times a day. What happens when you change the pattern? Something like that is there is prolonged hyperinsulinemia. Whenever we eat, there occurs insulin secretion, and whenever we eat junk, there occurs more of insulin secretions, both in frequency as well as in magnitude. When there is a higher level of insulin secretion at more than a physiological level, that chronic, there occurs insulin resistance. So this occurs in a vicious cycle: hyperinsulinemia pushing insulin resistance, and insulin resistance causing hyperinsulinemia. This is what is happening over a period of time, and it finally causes all the metabolic components of the metabolic syndrome. So what we had to do is we had to include fasting. We can even include in the form of intermittent fasting, in which we can eat, we can keep the eating window maybe 8 to 10 hours, and we had to fast the remaining 14 to 16 hours. This is what our ancestors has been doing. Our genes has not been modified or changed abruptly. It is a very slow process. So our genes are not accustomed. Our genes are thrifty genes. We are able to survive with very little of food. We are actually the cactus in the rainforest. We don't usually eliminate or waste the energy we take. What our current day society is facing, something like excess calorie intake, but a very poor micronutrition, the form of minerals, vitamins, phytonutrients, phytochemicals, because that is because of refining of food, because of ultra processing of food. Just because the ultra processing of food, we are getting rid of all the fibers, phytochemicals, micronutrients. All these are just depleted out of our food. Whenever there is a fiber deficient food, or fiber, there is no fibers in there is no fibers in almost all the foods what we are taking. Let it be polished rice, let it be wheat or any other form of diet, there is no fibers. Whenever there is no fibers, there occurs increased glucose spikes, and secondary to that, there occurs hyperinsulinemia. This occurs in a vicious cycle. So what we have to focus more on is we have to protect the liver. Whenever there is a increased glucose spikes and hyperinsulinemia, there occurs DNL, that is the de novo lipogenesis. That is the more of glucose is converted into fat. And in addition to that, the fructose that we intake in our daily life in the form of junk foods or all those things are directly converted into fat in the liver, causing fatty liver. So we have to move towards the unrefined grains, the two traditional grains. We have to move away from the ultra processed foods. And again, all this keto, paleo are very good, right? In the they are having a very common denominator. That is, they are avoiding all the ultra processed foods. They are taking the natural food, let it be vegetarian or non-vegetarian, doesn't matter. When you are getting rid of all the ultra processed food, we are bound to improve in our health status. But the only thing we have to look into is whether they can sustain it long term. It's not a matter of some few months or weeks, right? They have to have a lifestyle. They have to sustain it long term as well. What I have been seeing clinically in my patient is our traditional way of eating is very good. Our ancient wisdom is very wonderful. We have to explore it. And when we eat in such a way, with very good fasting, very good feasting, and in fasting in between, it's more than enough to have a very good insulin sensitivity, and we can get rid of all the metabolic components of insulin resistance as well.
Tangajore, just let me know what are the names of grains, and people always ask, ma'am, is it okay to take a meat? So what type of meat you would suggest, and what type of grains? Name some grains so that we can throw some.
Is it a processed food or natural food to us? It's quite natural, right? It's not processed. The processed food is what we have to move away from. So the meat is very good for us. But the only thing is whether we are accustomed to take all those things. That is what the first question is. When you are able to take all those things, meat, non-vegetarian foods, it's well and fine. It's not a problem at all. Only thing is we have to, what happens in this low carb diet is there occurs the insulin stays at a lower level, right? And the hyperinsulinemia just plummets down. And there is a reversal of insulin resistance. Secondly, to this reversal of insulin resistance and decreased insulin levels, all these hormones comes into balance, comes into harmony. This is what is causing the reversal of PCOS. Not only in low carb diets, let it be paleo or keto, I have been seeing patients who are taking traditional grains that are even reversing the PCOS, as good as the keto or paleo. What we suggest for patient is they can go in for short-term keto or paleo, maybe for 2 to 3 months, and they can move into traditional grains. That will be more sustainable for them. Is it clear?
Yes, yes.
Short-term paleo or keto is good. I'm just worried about the long-term effect of paleo or keto over a period of years. But short-term is very good. Maybe less than 6 months, you can go for it.
Might as well you should share us a nice recipe with all traditional grains so that we could also follow for our long-term betterment.
You mean you want me to say the name of the traditional grains, right?
Anything should be fine. We just want to know, see, at the end of the session, it is like give us some recipe or some diet plan so that we could convey in this video for the people to follow.
Sure, sure. For pregnancy, there is one traditional rice called Hunza. It's very good for pregnancy and fetal and maternal health throughout the pregnancy. She can take instead of the polished rice. And all the traditional grains are good actually. But with respect to pregnancy, whenever a woman become pregnant, our tradition is in such a way that they have to include this kind of rice in their diet. There will be increased polyphenols, increased antioxidants. There will be rich in phytochemicals, micronutrients in the form of minerals and vitamins. So this enriches them to have a very good normal pregnancy.
Tanguture, yeah, I have
Yes.
a doubt. See now, see many of them are working, whether married or unmarried. So they stay in
Okay.
PG. So they stay away from the family. It's very difficult for them cook and to maintain a very healthy lifestyle. Okay. So
Okay.
do you have any suggestions so that it? I mean, even the people who stays in PG can also follow this kind. So they just eat whatever is available to just survive. Is it? Yeah. Okay.
Well, it doesn't work that way. You have to eat the healthy food to stay healthy. You just can't eat the crap and expect to have wonderful results, right?
No, they are working, right? And they don't have time to cook and 3 times, I mean, whatever, 2 times.
Yeah, they can cook at least
And,
once a day, right? It is not a problem, right?
You would want to suggest some fruits and vegetables that would say prevent insulin resistance.
Yeah, they can also take fruits and fruits or sprouts for one meal. They can move on to fruits and sprouts. It's very good. It doesn't require any time at all. And they can eat twice a day. That's more than enough. But what they have been taught us eating all 3 times a day. It's not at all necessary that we have to eat 3 times a day to stay alive.
It's not.
Hello.
Every day eating green leafy vegetables, is it okay? Because some patient asked me, it contains a lot of chlorophyll and that is not good for the health.
The chlorophyll is too good for anyone, I would say, because it is nothing but its structure is more close to the hemoglobin in our blood. The only difference is the magnesium in the central atom has magnesium, whereas in our blood, in our the hemoglobin, there is iron. It is also called the plants, the blood of plants. What we call the chlorophyll. It gives the green color, right? It is also, it has a major benefit not only in this thing, but it has a major impact over the metabolism as well.
Is there any enemy other than the processed foods for insulin resistance? Say in any of the fruits or vegetables or anything else?
Yeah, sure.
Definite
Sure.
no.
Yeah.
We would want to hear.
We have to get rid of the juices, soda, all those things we have to completely avoid. And the fruit juices are as bad as sodas. We should not intake fruit juices. If you want to eat fruit, you take it in the whole form. That is what we suggest. And more of hybrids are available to increase the sweetness of fruits. That is not actually advisable. We have to move towards the tart fruits. That is the wild variety. That is more advisable in patients with insulin resistance or metabolic syndrome.
Equal to diet, I feel the sedentary lifestyle is also the main enemy. Sedentary lifestyle. Sedentary lifestyle. Comparing with our ancestors.
Yes.
Very minimal activities.
Yes. For maintaining a healthy metabolic rate, we need to have a increased lean body mass, right? In the previous days, maybe a generation before us, they didn't even know what is a gym and what are all the physical activities. They are actually naturally they are involved in physical activities in the day-to-day activities, right? So there is no need to move into all those gyms, all those things. But what I suggest is they can even go for physical activity within the home itself. They can do some resistance trainings. They can lift some weights, and they can do something like jogging. All those things will help. The combination of physical flexibility in the form of yoga and also the aerobic exercises, along with resistance training. The squats can help a lot for resistance training, and also the weightlifting in the form of dumbbells. Yeah, they can do all these things, but all these things are just to not to waste the calories, but to tone up the muscles. When we tone up the muscles, there occurs an increased lean body mass, which maintains an increased metabolic rate. Whenever there is an increased metabolic rate, we are not prone for obesity. Is that fine?
Yes.
That answers your questions?
Yeah, I think we have done almost, we have covered all the areas. So Tangadhara, you want to give us some take-home messages so that people who watch this video gets benefited?
There is also something like that seed cycling. I think you would be aware of that, right?
Pardon? Come
Seed
again?
cycling.
Okay.
Seed cycling.
Seed cycling.
Yeah.
So we busy gynecologists are nowhere and connect with the external world. So you please explain to us what is that?
Okay, fine. That is, we are focusing more towards intake of natural estrogens and natural progesterones. That is the phytoestrogens and phytoprogesterones that is in the seeds, in accordance with the reproductive cycles. In the first 14 days, they can take something like pumpkin seeds and flax seeds, which are rich in phytoestrogens. And in the next 14 days, they can move for sesame seeds and sunflower seeds, which are more in natural progesterones. That often supports this cycles, their reproductive cycles.
Know that? What do you call that as?
Phytoestrogens.
No,
phyto.
No, I'm asking this process. What do you call that process as?
Seed cycling. We have to seed cycling. We are using seeds, right?
Okay. As per the physiological pattern of the cycle, you give an estrogen-rich seeds in the beginning and progesterone-rich seeds in the later half.
Yeah.
It's nice to hear. We would also want to try such things. And
sure. You can include in the diet. It works well.
Okay. Yeah. Thank you.
You said we have to avoid seed oils, and now you say that it's good to take the seeds. And what's the difference?
Yeah, sure. What we have been taking in the traditional way is the cold pressed oils, right? And what we are consuming now is refined oils that are produced from the seeds, that are produced from the petroleum products, that are ultra refined. There are more of chemicals and deodorants are, and these oils are subjected to very high temperatures, so that they are converted into trans fats, and they are very much inflammatory, very rich in omega-6. That is what we have to move away from. The seeds in natural form is very good, but when it is ultra processed, it becomes a toxin.
Okay. Then what kind of oil we can use in cooking? Actually, majority of
the saturated fat. The saturated fat is actually good for you. Let it be coconut oil or ghee. And what we have been traditionally used in our Tamil Nadu is sesame seed oil. It's very good. We have to move away from pupa. All the ultra processed oils, all the refined oils are pupa, and they are claimed as cholesterol heart healthy. It is not so. It causes chronic inflammation that is more that is causing again derangement in the metabolic health.
Okay. Okay. Very nice. I mean, it's a new point for me. I don't know about others. Okay, it's very valuable.
Okay. Any other questions?
No, I think we are all covered most of the topics, and we can wind up the session and meet for a different session. So just give us a few messages at the end of the session so that we can close the session.
Okay, fine. So the PCOS, what we have been thinking is the hormonal imbalance. So the hormonal imbalance is secondary to all the metabolic effects, and the metabolic effects and the hormonal imbalance are secondary to the food we take, the environment we live. So we have to change the environment. We have to have a very good and healthy lifestyle. We have to move away from the ultra processed foods, refined grains, and particularly the sugars. And move towards the traditional grains, and we have to move. We have to live in harmony with nature.
Thank you,
That was-
Tangadurai. Thank
Yeah,
you for initiating this discussion. Thank you, Dr. Pratika, Dr. Vani.